Yeah, I guess I'll get into this a little bit so that way you guys can see it. So, biggest thing for me, I'm a physical therapist by trade. By practice, I started in sports and orthopedics, so you can imagine what is normal physical therapy, right? You go anywhere, have issue with your knee, your back. I see patients with all of those things as well. But I also specialize in male pelvic floor physical therapy. We'll get more into what that actually entails, but a partner and I practice with in conjunction with a lot of the oncologists in the area, some of the urologists, a lot of the PM&R physicians dealing with pelvic pain, post prostate cancer, post bladder cancer, colon cancer, all of those types of things as well. Anybody dealing with pain, incontinence, any other issues stemming from back pain, erectile dysfunction, anything in that realm. So there's a lot of crossover, a lot of conversations that go with different ones that you have with potentially an oncologist, urologist, primary care, as you're going through this process. So this thing worked. There we go. So physical therapist is really where my training comes from. I got my doctorate degree from Arkansas State University. I have a master's degree in sport and exercise psychology from Boise State. I was a GA, I was a graduate assistant over there. So I taught classes. I worked with the older adult strength and conditioning program, did lots of research, statistics. My specialty was human growth and motor learning. So really that gets into, from a teaching perspective, that's really where my specialty is like, hey, when somebody has to get back to doing a specific task, whether that be holding in their urine when they're doing activities or learning how to defecate again if they're having pelvic pain or a reverse colonoscopy or colostomy bag reversal, anything like that, from pelvic pain to strength and conditioning. So whether it's you're trying to just hold your grandkids or you're trying to lift 500 pounds, the specialty kind of spans that spectrum. From a male pelvic floor specialist standpoint, I can be honest, it's not something that I originally thought I was going to be doing. Going through school, my master's degree, I was very much in the sports performance orthopedics realm of life. I was planning on working in some capacity with professional team, all of that. And going through school and being a male myself, we went through a class in which one of our faculty members was a specialist in pelvic floor physical therapy. Well, kind of blew my mind a little bit. I was like, this is an entire area that I already have grad school experience that I've never heard about. So why have I never heard about this? So having prior grad school experience, I kind of did a deep dive, took extra classes outside of my school curriculum. I traveled to a couple states a little ways away to be able to take these classes to learn a little bit more. Found out I was like, oh, this is actually needed. It's necessary. There's not a lot of, there are very few physical therapists that are specializing in the male pelvic floor realm. There are even fewer men that are specializing in male pelvic floor physical therapy. So I'm one of two or three male providers specializing in this area, not only in Cincinnati or this like local vicinity, but honestly in the tri-state. So I have patients coming from 4 hours away in the middle of Kentucky to come see me, from prostate stuff to pelvic pain, people coming from Cleveland, Indiana. So it's a much needed, a very necessary field. And we'll talk more about what we're potentially doing well in healthcare and what we're not doing a really good job at, probably, or at least in my opinion. So, especially in helping men. So to further that, why I got further into it was that faculty member. Like most men, you can imagine that we're very purpose driven. So there has to be something that moves us forward. It's either annoyance of some sort or caring for somebody in a certain way. So mine being a male, this faculty member, they were actually starting a program at the university that was a women's pelvic floor program. So I took that at the time. Jim, we already talked about, I was going through, I was in the middle of COVID when I was in the middle of my doctorate degree. So I started in person, we did Zoom, and then we finished in person. So in the middle of this bout, they were starting a program that was only for women. So on my side, I was like, well, I think men need this too. Very underserved, very underprovided in terms of the profession and healthcare. And there's a lot of men out there that are having issues from an incontinence and pain that maybe just don't speak up. They don't know about it. They're unwilling to talk about it. They're scared. It's not normalized in that way. So I took that as a challenge and started my own practice upon graduating, in which I specialize in it. So until actually probably 6 months ago or so, I was actually I was the only male pelvic floor provider in the Cincinnati area. So which is pretty crazy if you think about it. There's a lot of men that are having prostate-based things, cancer, pain, lots of misunderstandings in that area. So I see quite a few of them. So pretty good background on that side. So I'm not going to deep dive. I was talking earlier. I've been to one of these meetings before when Dr. Kotlov from St. Elizabeth was talking about some new cancer treatment things that I found interesting that I actually myself wanted to learn about. So I'm not going to deep dive this a lot, but in terms of prostate cancer, its prevalence, from statistics wise, 1 in 8 men is going to be diagnosed with it at some point in their life. Obviously, we can get into the realm of colon cancer, bladder cancer, those things. You can imagine the amount of men that is going to be diagnosed with some form of something in the pelvic floor region. That said, prostate cancer, 4th most common diagnosis in the world. And who knows, because I mean, at the end of the day, how many men are coming forward? How many are we actually getting accurate diagnosis for? It could be even more, just based off of medicine doesn't do a really good job at getting some of the people who need the most care, the care that they need, or diagnosing them appropriately. So I want to go over treatment options. Again, I'm not going to go crazy with these. I think there are people that you are going to have on as guests, and many of you are honestly you probably know more about this than I do at the end of the day because you've either gone through it or you've had more speakers in here for this. I really want to touch on how quality of life is affected and what we do on the backside of this after treatment, before treatment, and then during treatment as well. So obviously we have active surveillance. Everybody knows what that is from a monitoring approach. Obviously if cancer is not aggressive enough or it has not progressed enough, that's really where that's just it, monitoring it to see if it's going to progress or go any further. You have the surgery options. So you have the radical prostatectomies. You have the laparoscopic. So where you're taking out just pieces or trying to clear margins without removing the whole thing. And sparing certain things within the prostate as well that affect levels of incontinence. You have radiation, so obviously high energy rays to kill cancer cells. You have your hormone therapy, many times targeting testosterone, a few other options there just across the spectrum that can be useful depending on who your oncologists are. You have cryotherapy, so the freezing of things, and then you have the high intensity focused ultrasound. And each of those have their positives, negatives. Again, I'm just not going to deep dive those. We have other things that I think I can contribute to for you guys' education. So the effects, funny little cartoon off to the side, usually gets a good laugh whenever I put it in there. So if any of the people watching this or in this meeting at all have had incontinence at some point in time, it could be pretty socially demanding from an emotional component. Most of the good things that come from those treatments, remove or treat the cancer, great, fantastic. What does life look like after though? So they're not so good. With urinary incontinence, you have erectile dysfunction, you have loss of bladder control, you have pain with urination, you have pelvic pain, you have nerve damage. And with the asterisks in here of these vary widely. So, and honestly, wildly at the end of the day. We have men that will come through that you could have a radical prostatectomy and you could have almost immediate control of your bladder and very little incontinence as soon as you're taking certain things away from you. You have other people who are years, decades down the road that they've had these procedures and they are still incontinent to a point where they're wearing Depends, briefs, all of the things multiple times a day that they're changing. Erectile dysfunction is one of the things that many men also have the issue from a relationship standpoint with their spouse, a confidence issue at the end of the day, all of that goes with it if you've ever experienced it. Loss of bladder control. So with this, that really ties in well with the nerve damage. The one thing that we talk about within pelvic floor rehab is if you don't have the ability from a nervous system standpoint to feel or sense something, as if, if you're leaking from a incontinence standpoint, if you don't even have sensation to know that, or if you don't have sensation to know when your bladder is full, your prognosis for quality of life changes over that time frame. Of what we can actually do from a more conservative route versus do we refer you out to a urologist or other providers in order to help get that under control. Then we get into pain with urination. So whether it's a burning, whether it's any sort of stabbing types of pain, just because of the procedure of taking the prostate out itself. We'll go through anatomy here momentarily, but that can be just that, right? It can be painful. And then pelvic pain is more so, obviously, it could be with erections, it could be with urination, that could be in the testicles, that could be in the perineum, that could be in the sphincters, in the low back. All of those things are connected. I have a little drawing or a little anatomy thing up here in a second. So there's a lot of things that can go into the hormone therapies, testosterone therapies, the radiation, the radical or laparoscopic prostatectomies as well. From a understanding of the pelvic floor. So if we're looking at pelvic floor musculature, I'm not sure if you guys can see my mouse here or not, but so if it says pelvic floor muscles, that little arrow that's right there, you can see that band that's leading up into the abdomen. So those muscles, there's another picture here shortly. So their role, what they do, you can see the purple, almost that walnut shape thing that's right there in the middle. That's your prostate. So if you don't have one of those, within the prostate itself, there's an internal sphincter. And then there's an external sphincter that is at the base of the urethra there as well. So basically you have two doors or two gates is kind of the analogy that I like to use. You can imagine that within a large prostate, it becomes, those gates get more dense in a way. So if you have benign hyperplasia of the prostate, so that's usually where men are like, hey, I have difficulty going to the bathroom. Like I strain to push. It's because it's actually closing off certain aspects of urine to flow through the urethra. But if you don't have that the prostate, you actually lose that internal sphincter. So that's where we get into the state of, well, if you used to have two gates and your body is used to having these two things that function well, now you only have one. So we're 50% there. Now we got to learn how to control what that actually does and how do we control the urine with movement, action, all those types of things. So the importance of the pelvic floor is being able to have some level of strength in it, some level of reactivity to action. If you're mowing the lawn, that is a different requirement than you picking up a grandchild or you getting out of bed. So the importance of maintaining this, though, is really it allows you to function from a quality of life perspective. But then also all of the functions that you want to be able to do, whether it's get erections, defecate, go to the bathroom, make it to the bathroom on time. If you want to go play 18 holes of golf, well, we got to be able to manage this. Got to be able to understand how to go out into the world and utilize different strategies from a movement, from a strength, all to get you through that day, which is really fun when we can get a guy to go from, hey, I had a radical prostatectomy 6 months ago to, wow, I'm playing 18 holes of golf. I didn't think I was ever going to be able to do that. And then you get some guys that'll come in, a couple years later, maybe not having been through something like this, where all of a sudden 2 months in, they're like, I didn't think I could do this. I wasn't able to hike. I wasn't able to go play golf. I wasn't able to play pickleball without leaking at all. And now we're just not wearing a shield or we're doing something like that. So we can actually control things better from a strength and coordination standpoint. So again, the role of male pelvic floor physical therapy. My job mostly is to educate people at the end of the day. There are a lot of things from behavior standpoint. There are a lot of things from a strength and conditioning standpoint. There are a lot of things from a just giving this, just like this presentation at the end of the day, is what do we actually do? How can we actually improve the quality of life for men across the board? By all means, pelvic floor physical therapy is meant to help women as well. They have their own levels of struggles with pregnancy, postpartum things. But men, at the end of the day, I think there's a lot of things that we just don't talk about. It ends up being, whether that's cultural, social, we just don't talk about it. Say, hey, hey, this is a real thing. With as many men as there are aging, and as many men have normalized incontinence or having to wear Depends, or brief shields, anything like that. While it may have been normalized, that doesn't mean that it's normal. So moving things forward, our job is to really give people the strategies, movements, conditioning, the understanding to move themselves forward from a functional standpoint and a quality of life. Because that's really it at the end of the day. From a mental health standpoint, the amount of men that I've found that as soon as we change some of these things, if we're already in a mental health crisis of sorts, if you've ever heard that as well, I can only imagine how many men are struggling with pelvic floor issues that we just don't get help and they just don't know. So it crosses spectrums of what this can do and what this actually accomplishes, in my opinion. So diagnosis and assessment, pelvic floor dysfunction, a couple things to go with. We're in the prostate cancer realm here at the moment. So with those treatment methods earlier, talking about treating cancer. So really, from an assessment perspective, the original and long-standing thing is the digital rectal exam. So just that, you've all had it. Urologist puts the gloves on, lubricates, and does the thing. Our job, though, as pelvic floor PTs, is to more so get a gauge of strength, of coordination. It is less abrasive, usually, what I would say. Patients are really good at telling us that, hey, like, actually, that wasn't as bad as what it has been before in the past. So it's not a quick, hey, this is very uncomfortable. It's a, hey, we need to get a few measurements. We need to check a few things, teach you a few things, and then that's it. That's really the prevailing method for most people. The unique piece is that we are now, from a technology standpoint, we don't really do the digital rectal exam from a post-prostatectomy, radical prostatectomy standpoint. We actually use diagnostic ultrasound. So in my office, we actually have an ultrasound machine. We can actually see the pelvic floor moving, doing what it's supposed to do. We can take some measurements, different strength measurements in that capacity to see, can you actually lift the pelvic floor? So from a component of looking at the diagram, you have different layers to the pelvic floor. You look at the ischiocavernosus on the sides of the penis there. You have the bulbospongiosus, which is the bulbospongiosus is the one that actually helps you with the quick flick. It's almost the ejaculatory state. So if you're having an erection and you have an orgasm, that's that like quick movement that you get from an orgasm, is that coming through. The ischiocavernosus is more of a maintenance of position, its stability. You get into the anus area, the external sphincter. So it's that same concept of defecation. So with the digital rectal exam, we'd be measuring and looking at how do you coordinate musculature how do you create stability, and then how do we manage incontinence. So we have to look at multiple different layers for patients to understand that full contraction requires a synchronized and coordinated contraction of all of those different tissues at the same time to help with incontinence. And then as things move along, as those coordinate better, erectile function comes along too. What we really look at, though, is you will not be able to have penetrative sex or anything like that from an erectile function standpoint unless you get your incontinence under control. Really within the realm of from a component of urination versus erection, you have to typically have one or the other. You can't necessarily be having an erection and urinating at the same time. While it happens, that's obviously not normal. What we're looking at is we have to be able to control that level of incontinence before we can get the erections back, before we get back to that state of normalcy. It also goes into the strength. So if you don't have the strength to close off or use that singular gate that is left, then you are going to leak through that. but you honestly won't be able to get the erection itself, just because it takes so much coordination to facilitate that process, along with as blood flows into the penis for an erection, the muscles around it have to be strong enough to clamp off. So that's really where like Viagra works in a way, or any sort of Cialis, any of those work low grade to help with blood flow. And that's, if anybody knows the story of Viagra, it was originally, the research was that they were working on some cardiovascular things, and they were like, oh, this actually works for other things, which is nice. It's one of the greater discoveries, right, from a component of quality of life. Many times maybe over prescribed, but from components of this, it is very functional to have those things work in conjunction together. And we work closely with the oncologists, urologists, primary cares to help facilitate, hey, what kind of pharmacology are these patients using to assist in this process for quality of life? So definitely something that we try and integrate across the floor, across the board. So that said, looking at coordination, looking at post-cancer type issues, there's more musculoskeletal things that are happening from a coordination, from a loss of function, from a can you relax, can you contract, do you have the strength to do those actions in general, or do many times we singularly go to one provider and say, here's a medication, here's the thing, just do that. While that can be helpful for certain things, many times, obviously, people are getting help with erectile function before they're getting urinary continence back, or even fecal continence, things like that. So yeah, attempting to find the providers that, depending on what you're looking for, quality of life is the thing. Spreading the floor to say, hey, here's what we need to do. So management strategies. Like I was saying earlier, a lot of what we look at is habits. We look at obviously movement, but pressure management. This photo to the right is actually looking at how do the lungs and diaphragm actually affect the pelvic floor. So you can imagine the first one in the blue, as you inhale, the diaphragm lowers, the belly expands, the lung fills with air. So if that diagram was a little bit larger, what you'd look at is the pelvic floor is below that. It acts as a bowl. So if you are looking at, say, the air is coming in, the pelvic floor sits down here. Well, if all of that pressure comes down, the pelvic floor drops. With a drop in that pelvic floor, that acts almost as a relaxation. That relaxation is putting pressure on the bladder. That's putting pressure on the external sphincter, the one that is that gate that is stopping you from urinating. So from an inhale, the fully inhaled position, that may be the most compromising position for most men, depending on where they're at from a continence, from a strength standpoint, specifically immediately post radical prostatectomy. That's what we see most of the time, is they get a little mixed up in terms of how do we manage the pressure. Many times it's going through things like this that are an immediate like snap of the fingers, like, wow, I'm actually more continent than I used to be, just because I understand how to coordinate my breath as well as the pressures inside my abdomen to make sure that I put myself in the best place to have the highest level of continence. You can imagine the other side, the exhale. So the lungs empty, the diaphragm rises. Well, the pelvic floor rises as well. So it comes up. If we're thinking about shortening, muscles shorten and they lengthen. Well, shortening is going to be the most contracted state. It's typically going to be one of the stronger states. So that said, the more that we can work within that realm to create a higher level of coordination and strength, the better. So pressure management is a big one that we use. Water intake is going to be the other one. When we look at urinary incontinence, the number one thing that we hear is men will say, well, I just stopped drinking as much fluid. Well, that's good and bad. That to acknowledge, like, hey, yeah, that actually does make sense a little bit, until we get into the body and the human is more complex. So when we look at the nervous system, your bladder is actually a component to it. Sends signals. As soon as it gets full, it sends signals to the brain to say, like, hey, we're full. You should go to the bathroom. And then based on those habits and behaviors, you typically go urinate. Well, what happens, and what I meant earlier by if you don't have sensation, well, we want you to be able to feel your bladder so you know when you're going. If you don't know when you're going, then you're probably leaking, or you're having some levels of incontinence. That said, if you can feel it and you can hold it, we want to be able to fill that bladder. That really looks like a from a measurement standpoint, we're looking at the stream of urine you should be having should be around 15 to 20 seconds every time you go. If it's any shorter than that, typically you're going too often. It means you're not filling the bladder to max capacity or to a 3/4, 80% full, which is fine. Of course, it's not an exact number. It's just more of a, hey, here's some guidelines for people to follow. From that component, if you're going too often, you're getting into a behavior. So much like you teach a puppy or a dog to have poor behaviors, or you teach them good behaviors, the subconscious side, the neurological side of your body works in the same way. So if all of a sudden you're teaching it, hey, we need to go to the bathroom, we need to go to the bathroom, I need to go to the bathroom every hour before I go on a road trip, before I go to the store, before I do anything like that, your body responds to that. You will also, as your bladder shrinks, because it is a elastic type property, as it shrinks, your body adapts to that as well. So when you actually go to fill it up, it actually fills up less, and your body responds as like, oh, we actually have to go now. So trying to maintain and change neurologically as well the behavior that you have from a urination standpoint is helpful. Many times that's just something where, yeah, from a common sense standpoint, sure, drink less water. But if you drink less water, we get into the realm of urination becomes more acidic. Acidity is actually an irritant to the bladder. So the bladder likes it's cool, calm, collected, a pretty neutral thing inside of it. If it gets too much uric acid, that really yellow, smelly, you are more likely to have to go to the bathroom sooner. So that said, if you are going all the time because you feel like you have to, if you're not drinking enough water, you're now double dipping into the realm of this is too much, and your body is adapting to negative behaviors at the end of the day. So that's where we get into appropriate toileting schedules, self-care techniques. We get into, okay, you need to actually go change your depends. You need to go change that. You need to make sure that you're cleaning yourself appropriately. You're taking showers. You're actually washing certain areas, because that's where we get into UTIs. That's where we get into trapped urine in the urethra, which happens. And of course, I think that's one thing men don't necessarily have to worry about as much as women necessarily as you get into older age, but it is definitely something that we see. Absolutely something where I've had patients come back and they're like, I feel sick. They're getting a little bit loopy in a way. Their significant others, like they're acting differently. What else is going on? That's usually what it is. That said, moving on to movement. So preoperative high intensity. What we look at is we try to get men in prior to these like radical prostatectomy procedures, prior to any sort of radiation, hormone therapy, anything like that. That is largely because we use it analogously to children or babies in a way. It's really easy to teach somebody something the first time if they know how to do it, if they have feeling. But if you have no idea what you're doing, and I go teach you 3 months later after you've had one of these procedures, and now you're like, I have no idea what I'm doing. I don't have any sensation down there. I don't have any strength. So it's easier to teach somebody when they do have some of that versus not. So similarly to somebody who has, was able to walk at a young age or something like that, and then they got injured. Well, it's easy to relearn how to walk if you've done it before versus, oh, you're 20 years old and now you're trying to walk for the first time. If you've never done it, it's going to take significantly longer. That said, we try to get men into preoperative high intensity based movement. And that really looks like, hey, how do you manage these different protocols or coordination of musculature or understanding what it feels like? Getting the correct, appropriate movement prior to those. So when you come back on the other side, you're like, oh, I remember what that feels like. I know how to get back to that point. That's really where we get into Kegels. If you've heard of them, they're not just for women. They are not the end all be all for men either. If you've ever gotten a piece of paper that has how to do Kegels on it, that's not it. We look at Kegels plus application of movement. It is functional movement. They are strength and conditioning principles. It is all of these things put together that matter and actually move you forward to the quality of life you want to have. Just because you go do Kegels 30 times a day and you hold it for 5 seconds as hard as you can does not mean that applies to when you want to go mow your lawn. That does not apply to going to play golf. That does not apply to going and trying to have sexual function in the bedroom. That does not apply to those things, because the environment, the actual capability of your body is different in those different positions. Of course, you could argue, oh, I'll just do it as I walk and do it as I do these things. You can do that. It may take you a lot longer. So usually that's our job, is to help say, hey, here's how we move forward. Here's how we get you there as quickly as possible. And honestly, take the guesswork out of it. That's the more important thing, because it can be so cumbersome and it does take time. That's the bigger thing, is many times we get into this realm of, well, you literally have a piece of your body removed, something that is no longer there. Your body now is all thrown into a loop. There are a lot of nerves that are in the pelvic floor, especially in the prostate, that your brain is now trying to reconfigure all of the things that you are trying to do and live the quality of life. So to expect it to be snap of the fingers, oh, everything's great, is short-sighted in many ways. So habits, we have seen the worst. Like I said, the best surrounding definitions of health and wellness from a component of how do we get men to move forward as quickly as possible. Bladder and bowel norms leading up to surgery. So really, I already went over that, what that really looks like. Getting into this is what we need to be doing from a pre, this is what we need to be doing from a post. But we also see habits from food intake, dietary, alcohol, coffee, all of the different things that are exacerbators and irritants to the bladder. And then honestly, they slow progress at the end of the day. I've had men come in and say, I drink 4 beers a night when I get home. That's what I do. I'm never going to stop it. And then we get to the point of, okay, well, if that is the difference between you and having the quality of life that you want from a continence standpoint, instead of having unnecessary urination when you don't want to, when you're out with friends or out with family, is that the thing that we need to change? So there's a lot of lifestyle behavior changes that we actually have conversations about. We get into abdominal and pelvic health outcomes, comorbidities, age, function, diastasis recti, which if anybody has seen one of those, or if you've ever had one before, or you currently have one, essentially that's a separation of the musculature in the abdomen. It looks like a bulge when you go to pick something up, bulges in the abdomen. Hernia repairs. So the confounding, those actually adjust that pressure management slide that we talked about earlier, from the inhalation and actually having the pelvic floor dropping down. We talk about pressure management, having a hole or a leak, big quotes, in terms of your canister. Well, that's the problem. And then we look at orthopedic issues. So if you're having any hip problems, if you've had hip replacements or labral tears or low back issues, and then mobilization of pelvic floor, of the abdomen, if you have different scar tissues, anything like that. And then we look at defining base level function of, is it just daily activities that you're trying to get back to? Is that all you really want to do? Do you want to be able to be active? Do you want to maybe go play pickleball? Do you want to go play golf? What do you want to be able to do? Defining those things and saying, okay, where are you at now? Where you were at prior? Where are you at from a strength standpoint? And then where are we at post in terms of being able to coordinate and move you there as quickly as possible? Movement, early onset, so high intensity. So we progress from the table. So that's where most physical therapy, if you've ever been before, many times gets a bad rap, because some clinics will have patients just stay on the table. Hey, you are 60 some years old, and we'll just keep you on the table because it's easy. And typically providers have 2 to 3 other patients at a time. That's not what we see as being the standard of care at all. So we progress from the table. We help teach from there. But we are up and doing as much as we possibly can. That said, if you've had a radical prostatectomy, the EMG, there's a little probe that they sometimes put up there post procedure. It's a nurse or somebody else is doing it. It is typically not a pelvic floor physical therapist. Essentially, they have you contract your external sphincter, so your rectum. Basically, you squeeze as hard as you can, and they say, "Oh, you're good. That's a Kegel. You know how to do it." But we already talked about that's not it. That's not all of it. So just because you contract one area of the pelvic floor doesn't mean you're getting the other 2. So the EMG is a helper. It allows us to see, are you actually able to contract those tissues or not? But it's only a small piece of that. So expanding the perspective of what does life actually entail, is really a component to the movement. That's where we get to nuts to guts. That's coined by a provider of pelvic floor physio that's out in Australia. She is actually leading a lot of the research in the pelvic floor realm. A lot of the current standard of care is actually based off of her dissertation and a lot of her research that she's been doing in terms of protocols, pre-post radical prostatectomies, the standard of care from a rehab standpoint post any of those procedures actually stems from her at the moment. So that's where we get into the nuts to guts, or the pelvic floor contraction, plus lifting, carrying, pushing, pulling, hinging, squatting, pressing, plus the pressure management. That all is what equals the success of patients at the end of the day, and how we manage and move forward from an incontinence perspective. We also then get into blood pressure, sexual health. Again, talking about Viagra, it was originally made for some of the cardiovascular stuff that they were looking into, but heart health is uniquely tied to erections. What we look at is, if you are unable to get erections, the first thing that we look at is the cardiovascular system. If it's erectile dysfunction type things, they're actually checking, hey, do you have any heart issues? Is there something else going on? And that's where we get into the return of the erections. So we have to go through those first phases before we get to the blood pressure management, before we get to the sexual health. And it is just a time thing. It's a moving you forward in order to get to that point, and then it's learning, educating, and skill training. So lifestyle modifications, really the stress of, hey, what we look at is we want men to intake 50% of their body weight in ounces of water. That's just water. That's not soda, it's not coffee, it's not juice, it's not milk. 50% of their body weight in ounces. So if you're 150 pounds, you need to be intaking at least 75 ounces of water a day. That's to maintain and keep proper hydration. That is a baseline metric. I don't think that should be a lot to ask, but sometimes, from a component of, hey, lifestyle things matter. If you're busy, I think getting at least 50% is pretty easy to do. Really, that's only 5-6 bottles of water a day. And if that's the standard to optimize your health and optimize maintaining continence over time, I think that's a really quick way for you to get to where you want to go with just a little bit of work. And then getting into regular exercise, proper nutrition, stress management. We're looking at fiber. We're looking at making sure you get enough fruits and vegetables. We're making sure you get proper nutrients. As physical therapists, we're not necessarily measuring those from a, hey, are we taking your blood? Are we doing anything like that? But those all do matter at the end of the day. The body is its own ecosystem. So the more that we can optimize everything else, the better. And from a standard of, hey, general physical preparedness, regular exercise, proper nutrition, and stress management are pretty status quo. I mean, if you can do those, you're going to have 80% of your life is going to be better at the end of the day. Add in some sleep things in there, like, hey, can we get better sleep? Great. I mean, if you can do those, you're doing better than 90% of the population across the globe. That said, if we're trying to come back from a radical procedure along with cancer, you can only imagine that should be fairly easy to manage over time, specifically if we're looking at what reoccurrence rates are for some of these things. So lifestyle modifications is a big one that we have conversations about as people move through time, because at the end of the day, I don't want to see patients back. My job is to not see them back in my office. I want to work myself out of a job. I joke with a lot of the providers, like, hey, some of the pain management, some of the other ones is like, my job is to put you out of a job too. So some friendly competition in terms of healthcare and how can we move patients' lives and quality of life forward, and then quality of care, because I think sometimes healthcare gets a bad rap of it's just expensive and just costs a lot of money. So questions with those things, I'm more than happy to answer any of them. I didn't see anything in the chat, or I haven't looked at it yet, but the biggest thing is seek help. So if you're having issues at the end of the day, please ask. By all means, none of this is necessarily meant from this presentation to be medical advice. Each person is very different from case to case. Of course, we see trends and principles along the way.